Hello friends, I am Dr. Farheen and let's do a rapid revision of preterm labor. So before understanding preterm labor, it's very important to understand what is term labor. So term labor is when the woman goes into labor after 37 weeks of period of gestation. So if she goes into labor before 37 weeks of period of gestation, it is known as preterm labor. If the baby is born before 34 weeks of period of gestation, then it is known as a premature baby because the lungs have not developed. There is this another term known as viability. So what do we mean by viability? That whether the baby is able to survive independently after birth or not. So this period of viability for India is 28 weeks, alright, and outside India, abroad, it is 24 weeks. So this is for outside India. Now let's understand why are we discussing preterm so much, because it can lead to a lot of neonatal complications. So what are these complications? To name a few, there can be pulmonary complications where the baby can later develop reactive airway disease or asthma. There can be hyperbilirubinemia because the liver is not mature enough to conjugate bilirubin. There can be failure to thrive, necrotizing enterocolitis. The baby can be prone to a lot of infections because of immune deficiency. There can be intraventricular hemorrhage or periventricular leukomalacia. Later on, the baby can have neurodevelopmental delay. The baby can also have retinopathy of prematurity, which can later progress into retinal detachment or blindness. There can be hypertension, there can be anemia, and baby at birth, although it is hypoglycemic, but later on as the baby grows, there can be increased incidences of insulin resistance and the baby can develop diabetes mellitus. So what are the causes of preterm labor? The most common cause is idiopathic. Okay, so the cause is not known. And the second most common cause is a previous preterm. So the second most common cause is previous preterm birth. So before understanding the causes of preterm labor, let's understand what are the causes of normal labor. So preterm is just that the labor is occurring before 37 weeks as all of the mechanisms are the same. So for any normal labor, there are two things which happen. There are regular uterine contractions and there is cervical dilatation. So what are the conditions which lead to premature dilatation of the cervix? So these are the conditions which cause intrinsic weakness of the musculature of the cervix, Mullerian anomalies, which can also lead to weakening of the cervix, or previous procedure done on the cervix like cervical biopsy or any operation done. Okay, and what can lead to irregular uterine contractions and what can lead to premature uterine contractions? So premature activation of the entire system of the labor mechanism. So what is it? First of all, over distension of the uterus. So whenever the uterus is over distended, what will it do? It will increase the gap junctions. There will be increase in the calcium ion influx. There will be increase in the oxytocin receptors. And all of this, what is it going to do? It is going to initiate labor, right? So what will lead to stretching of the uterine wall? Any over distended uterus, it can either be twins or polyhydramnios. Then intrauterine infection, bacterial vaginosis, asymptomatic bacteriuria, or premature or prolonged rupture of membrane. There can also be maternal conditions which can predispose to premature activation of the labor system like preeclampsia, diabetes. Severe anemia is also another common cause, antepartum hemorrhage. Now, what are the predictors of the preterm labor? How do we know that the women can go into preterm labor? What are the warning signs? So the best is the TVS measurement of the cervical length. If the cervical length is less than 25 mm or less than 2.5 cm between 16 to 24 weeks, then it is a predictor of a preterm birth. So on ultrasound, what you will see that this is the normal ultrasound. Okay, this is the head of the baby and all of this is the cervix. So we can see over here that the cervix is closed and this is the length of the cervix. So this gives the appearance of a T form, which is normal. As the cervix starts opening up, there will be funneling of the cervix from above and the cervical length will keep on decreasing, right? So this gives the effect of a Y. As the funneling increases, so we can see that the funneling has increased over here and the cervical length has decreased. So this is the V form, and when the cervix gradually dilates totally, it is U shape. So this is how the cervical insufficiency progresses on ultrasound. I have discussed this topic in detail in my topic on recurrent pregnancy loss. Please go through that also. So who are the women in whom we need to give prophylaxis? So we have divided women into high risk and intermediate risk. So who are these high risk women? We have to remember all these points and they're very important. Those who give a history of a previous preterm birth or a second trimester loss between 16 to 34 weeks, or at less than 34 weeks they had a premature rupture of membranes. Alright, these 2 points are similar. Then who have a previous use of a cerclage, which gives an indication that the cervix must be weak, who are a known uterine variant, again leading to weak cervix, who have intrauterine adhesions, and history of trachelectomy. What is trachelectomy? It is a therapeutic operation where we are removing a part of the cervix along with the upper vagina, and this weakens the cervix also. So what are we going to do in these high risk women? We will offer them transvaginal sonography from 16 weeks onwards. We will keep on repeating it every 2 to 4 weekly, okay, till 24 weeks. If between 16 to 24 weeks any time on TVS scan the cervical length comes out to be less than 2.5 cm, then we will perform cervical cerclage in these patients. Alright, remember that in the high risk group cervical biopsy is not included because it is included in the intermediate risk women. So intermediate risk women are those who have more than one procedure or a cone biopsy. So cone biopsy, the depth of the cervix which has been removed is much more, or who had a loop excision of the transformation zone where the depth was more than 1 cm, or all those who give a history of a previous full dilatation C-section. What do we mean by this? That they had taken a trial of labor, the cervix was fully dilated but somehow they did not have a vaginal delivery and ended up having a cesarean section. So what are we going to do in these women? We will do a single scan between 18 to 22 weeks, and if on the single scan the cervical length comes out to be less than 2.5 cm, then we will go ahead with the cerclage. Alright, so in all the intermediate and high risk women at the time of TVS, if the cervical length comes out to be less than 2.5 cm, then we will perform cerclage. Just in case, if in these women the transvaginal scanning, the cervical length is more than 2.5 cm, then we can go ahead with progesterone. Progesterone, the chemical used mostly is 17-alpha hydroxyprogesterone caproate or micronized progesterone, which is administered vaginally. We will start giving them from 16 weeks onwards till 34 weeks. Why do we give it till 34 weeks? Because at 34 weeks the fetus is going to attain lung maturity. Howsoever, the role of progesterone has been controversial. Few doctors tend to give it to the patients and few doctors do not give it. Alright. Now coming to the diagnosis, we have discussed the predictors, we have discussed the prophylaxis. Now coming to the main diagnosis of preterm labor. So if the woman comes to us, so we will monitor her uterine contractions. If the uterine contractions are more than 4 in 20 minutes, or if the cervical dilatation is more than equal to 2 cm, or if on transvaginal scanning the length of the cervix is less than 1.5 cm. Alright, now pay attention over here. Transcervical length less than 1.5 cm is the diagnostic criteria. What was the predictor? Predictor was cervical length less than 2.5 cm. Okay, so diagnostic criteria is cervical length less than 1.5 cm. So these are the clinical markers. There are other biochemical markers also. So there are few chemicals which are found between the fetal membrane and the uterus. So suppose this is the uterus, this is the fetal, and we have the fetus lying over here. Okay, this is the fetus. So there are few chemicals which glue the fetal membrane to the uterine mucosa. So the most commonly used test is the fetal fibronectin. It is a glycoprotein which is produced by the fetal amnion. It is a glue between the fetal membrane and the decidua. Now it is found in the cervicovaginal secretions at less than 22 weeks normally, and it is found after 34 weeks also. Few books mention this as after 37 weeks, but this value is not important. This less than 22 weeks is more important. So if it is found in the cervicovaginal secretion after 22 weeks, it means that there are chances that the patient can go into preterm labor. What is the cutoff value of fetal fibronectin? So cutoff value is more than 50 nanogram per milliliter. This, however, is not recommended routinely by ACOG. It has a very high negative predictive value. So what do we mean by that? That if on the cervicovaginal swab we have found that the fetal fibronectin value is less than 50 nanogram, then we are sure that the patient is not going to go into preterm labor for another 1 week. Alright. There are other biochemical markers also, you should just know the name. Insulin-like growth factor binding protein 1 and placental alpha microglobulin 1, all of these are glues which adhere the fetal membrane to the uterine mucosa. Now we know we have read a lot of theory till now, but what are we actually supposed to do when the patient comes to us? Okay, so a 31-week patient, second gravida, has come to the ANC with regular contractions. So what are you going to do? Before discussing this question, let's go through the basic concept over here, that if the patient goes in labor at less than 37 weeks, then this is your preterm labor, right? If the baby is born at less than 34 weeks, then it's a premature baby and the baby has not attained lung maturity, right? So what do we need to give? We need to give steroids. And if the baby is born at less than 30 weeks, then we need to give neuroprotection to the baby. This is according to the new guideline. And what do we give as neuroprotection? We give magnesium sulfate. Okay, so basically these are the two milestones that we need to remember, that if the patient is less than 34 weeks, we need to give steroid. If the patient is less than 30 weeks, then we also have to give magnesium sulfate in addition to steroid. Alright, now coming back to the question. So how are you going to proceed? She is at 31 weeks. So first of all, we have to be sure of her dates because we need to confirm her milestones, right? So what is the best thing to confirm her date? It is her viability scan. Many women are not sure of their last menstrual period, so viability scan done at 7 to 9 weeks is the best ultrasound through which you will calculate and confirm the dates. The second thing that you will do is that you will take history. And what is the commonest cause after idiopathic? It's a previous preterm birth. So you will ask the patient whether she had a previous preterm birth or not. Third thing, you will examine the patient because she can have other causes of preterm labor is infections, right? So you have to rule out urinary tract infections, constipation in this patient. So we have to monitor her pulse, blood pressure, temperature, if she's having fever or not, her respiratory rate. Alright. Now coming to the per abdominal examination. So what will we do in a per abdominal examination? You will check for her fundal height, you will corroborate for her period of gestation through that. You will check for the fetal heart rate and then you will check for her contractions. So what was the diagnostic criteria? More than equal to 4 contractions in 20 minutes, right? Then you will do a per speculum examination first. So in per speculum examination, first of all, you are going to take a high vaginal swab. Why is this high vaginal swab taken? It is taken for the purpose of GBS prophylaxis, okay? Group B streptococcus prophylaxis. And we will also check for the dilatation of the cervix if we are able to see, and if we are able to see show or not, okay? Only after the per speculum examination, we go ahead with the per vaginal examination. Per vaginal examination is only done if the per speculum examination is inconclusive. Alright. Now when this woman has come to us and we see that the woman is having contractions but it is not more than equal to 4 in 20 minutes, or the cervical dilatation is not more than equal to 2 centimeter. Alright. So what are you going to do next? Next we will offer her a transvaginal sonography to see for the length of the cervix, okay? If the length is more than 1.5 centimeter, we will discharge the patient because she is not going to go into preterm labor as of now. And if the length is less than 1.5 centimeter, then the diagnosis of preterm labor is confirmed. If we do not have the ultrasound facility, then only we will go for fetal fibronectin. So the investigation of choice first is TVS, okay? If this is not available, then fetal fibronectin is the second option. So what are the values for fetal fibronectin? If it is less than 50 nanogram per milliliter, again we will discharge the patient. She is not going into preterm labor. But if the values come out to be more than 50 nanogram per milliliter, then the diagnosis of preterm labor is confirmed. Just in case if on transvaginal sonography you have found out that the cervical length is less than 1.5 centimeter and you have confirmed the diagnosis, will you go for fetal fibronectin or not? So the answer is no, you will not go for fetal fibronectin. We only have to offer one of the either test, and in that also transvaginal sonography is superior than fetal fibronectin. Now there are three other terms that should be clear to you. What is suspected preterm? Suspected preterm is just that when the woman has her symptoms and you are suspecting that she can be in preterm labor. What is established preterm? That you have done her examination and you have found that she is having more than equal to 4 contractions in 20 minutes and the cervical dilatation is more than equal to 2 centimeter. So that is established preterm. What is a diagnosed preterm? So diagnosed preterm is that when you have done either the ultrasound or the fetal fibronectin test and you have confirmed the diagnosis of preterm. Now what is the management? So first of all, we will offer bed rest to these women. Corticosteroid therapy to all patients is offered who are less than 34 weeks. Role of tocolysis is just to substantiate the role of corticosteroid therapy. Neuroprotection is given to all those patients who are less than 30 weeks. Okay, and we give GBS prophylaxis to all patients of preterm labor when they go in labor. So if the woman has come to you, she is having preterm labor, you will not give antibiotic prophylaxis. But when she goes in active labor, when the cervix is dilated more than equal to 4 centimeter or she is getting contractions 5 in 10 minutes, which is the sign of active labor, then you will go ahead with the GBS prophylaxis. Alright, so let's discuss them in detail. Corticosteroid is given between 24 to 34 weeks. Why have we chosen this term 24 weeks? So 24 is the period of viability, okay, till 34 weeks, because after this the baby is going to attain lung maturity. So dexamethasone is given as 4 injections, 6 mg 12 hours apart. Betamethasone is given as 2 injections, 12 mg 24 hours apart. Okay, so after 24 hours of last dosage of steroid or of last steroid dose, lung maturity is attained. Okay, so then after giving the steroid we have to wait for 24 hours. So both beta and dexamethasone, they protect against respiratory distress syndrome. They have asked this as a question. Additional benefit of betamethasone is that it also protects against intraventricular hemorrhage and necrotizing enterocolitis. For all practical purposes in India, dexamethasone is preferred because the original salt of betamethasone is not available. Okay, so these are all the controversial points that I have touched upon. Now coming to another point, magnesium sulfate. Again, it is given from 24 to 30 weeks, ideally till 29 plus 6 weeks, less than 30 weeks. Okay, so it is a neuroprotective agent. It is also a mild tocolytic. Okay, it is given as 4 gram intravenous bolus of magnesium sulfate over 15 minutes, followed by IV infusion of 1 gram per hour until birth or less than 24 hours, whichever is sooner. Okay, it is not given along with nifedipine. Why? Because nifedipine is a calcium channel blocker and it is going to antagonize the effect of magnesium sulfate. So if any tocolysis is required, although magnesium sulfate itself has mild tocolytic property, but a strong tocolysis can be required. So what is the tocolysis of choice here? Tocolysis of choice here is atosiban. Okay, this they have asked as a question in your NICT exam. Now intrapartum antibiotic prophylaxis. So stress upon this word intrapartum, which means that when the patient goes into labor, intrapartum prophylaxis is given to all patients who go in active labor. Okay, what is the drug of choice? Drug of choice is injection benzyl penicillin. But if the patient is penicillin allergic, we will give her cephalosporin or vancomycin. Now tocolysis is given till 34 weeks of period of gestation, only till we will wait for the effect of, so that we can wait for the effect of corticosteroids and magnesium sulfate. Okay, only for that purpose. When it is not given, when we see that the delivery is imminent and it has no use. So when the patient goes in active labor, when there is intrauterine infection, and when you need to speed up delivery, like if there is fetal compromise, placenta pre-abruption or eclampsia. So what are the tocolysis that are used? Calcium channel blocker is the first line and it is the drug of choice. So there are certain side effects and precautions that we need to take. So it can cause hypotension, flushing, headache and nausea. Okay. Coming to magnesium sulfate is a tocolytic as well as a neuroprotective, and again it can lead to headache. We also need to monitor magnesium sulfate for magnesium sulfate toxicity. So how did we used to monitor? By knee jerk, urine output and respiratory rate. Okay, same monitoring as we use in preeclampsia. Indomethacin is not given after 32 weeks because it will lead to premature closure of ductus arteriosus and also oligohydramnios. Atosiban is oxytocin antagonist. It is a drug of choice in heart disease patient and also in patients who are on magnesium sulfate, but it is little expensive. Nitrous oxide can also be given, but as a patch, it can also lead to headache and hypotension. Coming to beta mimetics have a lot of side effects and generally they are not preferred. Okay, so the tocolysis of choice is nifedipine. Tocolysis of choice for heart disease is atosiban. Again, tocolysis of choice for magnesium sulfate is atosiban, and tocolysis which is not given after 32 weeks is indomethacin. Coming to beta mimetics, it has a maximum side effect and the most common side effect is tremors. Other side effects are hyperglycemia, palpitation, headache, pulmonary edema. Therefore, it is contraindicated in patients with diabetes mellitus and heart disease. They have also asked a lot of questions on tests for fetal lung maturity, so I have touched upon them. The best method which is used is phosphatidylglycerol. Okay, so this is the best method. It is also the best method in diabetic females. Other methods used are lecithin sphingomyelin ratio. If it is more than equal to 2, it indicates pulmonary maturity. Shake test or bubble test, also known as Clemens test, is a best side test. So what we do in a test tube, we take a amount of amniotic fluid and we mix it with alcohol and shake it. Presence of bubbles indicate fetal lung maturity. Foam stability test is there. More than 47 indicates pulmonary maturity. Another is saturated phosphatidylcholine. Remember, this is phosphatidylcholine, but the investigation of choice is phosphatidylglycerol, right? Amniotic fluid optical density is also done, and more than 0.15 at 650 nanometers indicates pulmonary maturity. Lamellar body count represents the storage form of surfactants, and if the count is more than 50,000 per microliter, it indicates pulmonary maturity. Nile blue sulfate test is also commonly done. So we mix amniotic fluid with Nile blue sulfate dye. Presence of orange colored cells indicate pulmonary maturity. So this was all about preterm labor. Thank you so much.